Hello, good afternoon, everybody. I'm very glad I can be here. I would like to thank the organizers for inviting me, and it's a great privilege for me to welcome you in my home city in Prague, although I was born in the other part of the Czech Republic. My task today is to discuss with you some cancer issues. I would like to introduce myself, and I would like to introduce my alma mater. Probably you are very well in the history and in the, you know, the Prague. But I would like just to remind you that the Charles University was founded in the 1348, and it was the 18th. It is the 18th oldest university in the Europe. You can see that the first university was founded in Bologna in 1088, and the Prague University was founded in the 1348, and there are the other universities are younger compared to Prague. The Charles University was founded by the Charles IV, who was the emperor, the Czech king, and the German emperor. And this is nowadays this is the building, the medieval building where the hall of the university is placed, and the headquarters of the university have the offices here. Actually, because we are almost all, we have some connect with the religion, we have some connect with the Protestant movement. The Jan Hus, you probably all know this name. He became a rector of the university. He was rector for 2 years, 1409 to 1410, and he was a preacher in this time in the Bethlem Chapel, which was founded in the 1371, and this is a copy of the old chapel, and I hope you will have some time to visit it as well. This is my hospital. I work in it. This picture was drawn in the 1843. And you can see that the building looks very similar, only the cars are a bit different nowadays. And just some curiosity, this is the picture from my office. On the picture is Professor Krumholtz, who was the head of the medical department in the first half of the 19th century. And there is a couple of the stories which I have found. One story is that he resigned when he was 54 years old. It means it's my age, so I have to think about it. And the reason was that he felt to be too old to follow a rapid development and movement in clinical medicine. It was in 1836. He moved to the chair of the physiology department, but his heart was always within the buildings and within the hospital. And his last wish was his heart stayed forever in these walls. And you can see here, this is a picture of the vase. And in this vase is indeed his mummified heart from the 1843 when he died, and it's placed in my office. So this is very short introduction. I'm hematologist. I'm hematologist oncologist. I'm the head of the department. My field of expertise is lymphoproliferative cancer. It means the leukemias, lymphomas, multiple myeloma, and I used to serve as a director of the Institute of Hematology and Blood Transfusion, and I'm the chair of the Czech Lymphoma Study Group. I would like just to discuss with you some issues, and I would like to start with a history, because I think that we have to learn, because our our ideas are not very different sometimes, and we can found these ideas back deep in the history. So the first description of cancer is in the Edwin Smith papyrus, which was found in Egypt. I was unable to find exact dates because it varies. I found that it was the birth of this papyrus was around 1600 before Christ, but there are some reports that it's older, but definitely it's summarized the experience of the Egyptian physicians or the priest. And this is an ancient textbook on trauma surgery, but in this textbook there is a description of 8 cases of the ulcers of the breast, which can be a breast cancer. And what is interesting, that they try to heal it by the local approach, catheterization with a tool called the file drill, but at the end the writing says that there is no treatment for the disease. And this papyrus is describing many of other therapy as well. This is a mummy of the around 50 years old man, which was discovered, and the man died approximately 300 before death, and it was revealed that the man suffered from the metastatic prostate cancer. You can see that here is a fossa, prostatic fossa, and there are the column, and you can see the sclerotic lesions here in the columns. It means this is one of the findings the people made in these mummies. There are some findings which were older, but this is a picture I found in just recently in the International Journal of Paleopathology. The Hippocrates, around 400 before Christ, used for the first time term carcinos and carcinoma to describe non-ulcer-forming as well as ulcer-forming tumors. These words refer to Kreb, and the Roman physician around our age, only couple decades before Christ, translated this Greek term into the cancer, the Latin word for Kreb. And the Galenos, who lived in the 2nd century, another Roman physician used the word onkos. It means we use the oncology and hemato-oncology, and this is his word. What about the causes of the cancer? The Egyptian physician who used to live around the 1 century or 2 in the 2nd century after the Christ, he described 2 of distinct forms of cancer. The one was firm to the touch and non-ulcerated. The second one was smelling and ulcerated. And Claudius Galen believed that there is a black bile which caused the ulcerated and incurable cancer into opposite to the yellow bile, which was responsible for non-ulcerated and curable cancer. And it was in the 2nd century, and Andreas Vesalius, who is a father of the modern anatomy and who wrote the book on the modern anatomy, he tried to prove the black bile theory. But then he presented that he failed. It was in the around the 1540. And 1 century later on, the Gaspar Asselli discovered the lymph, and the William Harvey described the blood circulation. So it means that later on the fluid theory, the lymph theory was established, that the benign tumors are caused by the local coagulation of the lymph compared to the malignant cancer which arose from the fermentation and degeneration of the lymph. And we are in the 17th century. In this century, the microscope was discovered by Leeuwenhoek in Netherlands, and this discovery was very important for the next discoveries. The Herman Behavior in the early 18th century, he believed that the tumor is caused by accumulating substances which what we called a cancer virus, which he expected to came into the body from outside, and these viruses accumulating, and you can hear the viruses, but he hasn't the idea that it's a biological entity. He considered that it's really the toxic substance, and but the term of cancer virus was used in these days, and very important still was the role of lymph, which was thought as a reservoir of these toxic substances, which finally and ultimately caused the cancer. In the second half of the 18th century, the London surgeon John Hale wrote the book Cautions Against the Immoderate Use of Snuff, Tobacco, and he wrote that the tobacco snuff is able to produce swelling and polyps in the nose, and this is the first description, the connection between tobacco use and the cancer. So it's just is a curiosity, but I found it interesting. In the 19th century, the new theory was established, and it was established based on the cell theory. It means that in the 1838, the Theodor Schwann declared that the tissues are composed from the cells. And later on, the Rudolf Virchow and Karl von Rokitansky and the others declared that the cells are coming from the cells. It means that the cells do not originate from the humor, from the fluids, from the tissues, but the cells has origin in the other cells. And this is important because in these days, or in these years, was established the theory that the cancer is arising from the cells. It means that this is not a fluid disease, but this is a disease which has roots in some wrong cells. So, when we try to recapitulate what I have said is that in the 2nd century, the black bile theory was announced, and it was disproved in the 16th century by the Vesalius. Then a couple of centuries, the fluid theory or lymph theory or viral theory was used. And in the 19th century, the cell theory was established. And now we move to the cancer cells, to the descriptions, what we think is important to understand what is going on in the cancer cells. In the early 20th century, the Theodore Boveri came up with a theory that the cancer has something to do with the number of chromosomes, with the material which was believed is important for the cells. And in the 1960s, the Noel and Hungerford, for the first time, described the connection between chromosome aberration and malignant disease. It was the chronic myeloid leukemia, and the chromosome they discovered and described was called Philadelphia chromosome, which is translocation, which is 22nd chromosome, and it's caused by the translocation of the 9th and 22nd chromosomes. In the 70s, it means it's not too far, the Knudsen formulated the two-hit hypothesis. It means that if we expected the cancer, we need several hits. One hit itself is not enough to create cancer. It means that one is a promotion and the second one is initiation event. And later on, some oncogenes and proto-oncogenes were described, and some epigenetic alteration, and we can hear a lot about the epigenetic because it's important to know that although we have genes and genes are expressed and genes are translated, that there is a lot of additional processes which we call epigenetic, and they modified what is transcribed and translating to the proteins. And the first human tumor suppressor gene was discovered 30 years ago. And this is a stepwise, the several hit theory, when there is a stem cell and there is some hit which onset and some secondary hit finally cause the cancer, and the other cells usually die. It means that for the formation of the cancer, we need there is necessary that the several conditions have to be filled. But now, just to be underlined that we are talking only about the cells itself. Very important project was started 20 years ago, the Human Genome Project. The aim of the project was to describe and to understand the whole genome of the human. It means the whole genes should be described, and as a final ultimate output of this project was description of the number of different genes, oncogenes and protogenes, and only 7 years ago the first human tumor exomes are sequenced, and now we have several consortiums, and the first human tumor genome was sequenced 5 years ago. So this is very rapid movement, and I still have to memory the Professor Krumholtz about the rapid movement in the clinical medicine. So, but is this event within cell, is it enough, or what really happens in the body? I'm a hematologist, so I deal with hematopoiesis, and hematopoiesis is this is one of the nowadays accepted models, but only one. And it says that there is a long-term repopulating hematopoietic stem cells. It means that we have only several hundred of these cells which are repopulating itself, and they can differentiate it into the different lineages, like a myeloid lineage, the erythrocyte, platelets, granulocytes, macrophages, and dendritic cells are coming from, and the lymphoid lineage, where the B cells, T cells, NK cells, and some dendritic cells are coming from. It means this is a theory about the human stem cells, which is now hematopoietic stem cells. And in the 70s, for the first time, was on the mouse model, was established that you can transmit the leukemia from one animal to the other animal only if you use couple of cells. It means that these cells can play the same role as the hematopoietic stem cells. The only difference is that this is not a normal stem cells, but this is the leukemic stem cells. And the leukemic stem cells can be on the level of the truly hematopoietic stem cells or on the progenitor cells. And it is important to understand because this is very important later on when we come to our approaches, how we can eradicate the cancer. It has been discovered that the stem cells need their own home, their own room, where they can sleep, where they can survive, they can be wake up, but they are in a safe place. And this is what we call stem cell niche. This is the term which we use. And here we can see the bone marrow, and here there is a hematopoietic stem cells which depends on the osteoblast, on the intracellular matrix, on the stroma cells, on the other cells. So it means that they have their own home and they are very safe in this home, and they can finally to repopulate the whole body when somebody happens. But this is not only for the hematopoiesis. This is true for, let's say, epithelial cells in the intestine. They have very limited number, very special field we called the niche for the small intestinal cells. It means it's again some protected place where the normal stem cells are placed in. But the problem is of the cancer that this cancer can exploit these protected places. And the theory of the cancer stem cells is very important and very crucial. And we can find the places, for instance, this is the tumor cells which express some adhesion molecules, some cytokines, and he just trying to settle and to set up his own niche, his own stem cells. And this is the crucial point in our fight against the cancer. What about our treatment approach? I think we all can recognize the plants, and what we usually can do, we just try to cut the plants. But what happens? The roots are in the soil, and when we come a week, 2 weeks, month later on, we found the plants again. And this is very often the same story when we try to treat cancer. We treat the mature cells, or we eradicate the mature cells, but we are unable to eradicate the stem cells. I just try to use one example, and this is the example I have already mentioned. In the 1960s, the first chromosome aberration was linked to the tumor, to the chronic myeloid leukemia. And I have already mentioned the Philadelphia chromosome, which is the chromosome 22nd, and you can see that there is a exchange of the material, exchange of the genetic material on the chromosomal level. The bottom line is that it forms the gene, BCR-ABL gene, which then is transcribed and translated to the BCR-ABL protein, which is a tyrosine kinase. and this is relatively unique situation because if you remember that we need several hits to create cancer, this only event is able to create the chronic myelogenous leukemia. And when I was a student and when I started to work as a physician, almost all people die within 10 years, and 50% died within 5 years, unless they have the chance to undergo this allogeneic stem cell transplantation. In the 93, a substance which was called ST571, later on imatinib, was discovered, and it has been shown that it specifically blocks this tyrosine kinase. It means this is a specific act on the leukemia cell, and it has a really revolution in the field of medicine. This is the cover page from the time, from the 2001, and you can see that there is a new ammunition in the war against cancer, and these are the pellets, just the pills, the magic pellet, which can cure the cancer. But what we have learned? Definitely. You can see that this is our own data from my institute, and you can see that when we treat the patients with the chemotherapy only, 4 years after the diagnosis, only 1/3 of patients was alive. When we used the interferon, which is the biological agent, it was around 50%, but at 10 years, you can be sure that all people are dying. When we use imatinib, you can see that in the 4th years of the treatment, 95% of patients is still alive. And there is a projection that at the 10 years, it's almost 85% the patients is still alive. But it has been found that the imatinib targets the mature cells, and the imatinib is unable to target the leukemia stem cells. It means that if you stop the treatment with imatinib, although you have no signs of the leukemia in your blood smears, in your bone marrow, then you can be almost sure that you will face with the relapse of the disease which onset from the stem cell. It's not completely true. If you try to withdraw imatinib in the patients who have been in so-called molecular biological remission, it means that you are unable to find any cells within 1 million of cells or 100,000 of cells, that around 50% or 40% of patients can be alive without imatinib. But the rest, within 3 up to 6 months, they relapse on the molecular level. It means that the drug has to be introduced itself, and we have several other classes of this drug. So, how it is happened that this drug, which is very active, is unable to eradicate the stem cells? And one of the explanation is that it is due to the niche. Because the stem cell is placed in its own protected place, and the drug is unable to target efficiently the stem cells. But it has been proven in the hematopoietic stem cells. It was published a couple of years ago in the Nature by the German group, that you can by some drugs, in this case interferon alpha, allow the stem cell coming out from the niche. And at this time, it's unprotected, and you can hit it. And it was found in the retrospective analysis. There is some hint. There are the people here on the white line who was treated only with imatinib, and on the red one, there are the people who have been treated before with the interferon alpha. It means in these cells there is a bit higher probability to eradicate the stem cell. So, when we are talking about the cancer, are we talking only about the tumor cells? Definitely not. One of the physicians in England, Thomas Hodgkin, described in the 1832 Hodgkin's lymphoma, what we call now Hodgkin's lymphoma. There was a couple of theories around 20 patients with enlargement of the lymph nodes, which at this time were believed that it's not caused by some infection. In the hospital in England, some specimens were found and preserved up to date, and you can see that its examination from the specimen 180 years old, and you can see that this is the disease where the Hodgkin's lymphoma or the Reed-Sternberg cells, Hodgkin cells or Reed-Sternberg cells are present, but they are in the minority. If you have, or if we have the patient, and this is just one of my patients, he's just in ward, and we have just now proved that he has the Hodgkin's lymphoma. You can see the huge tumor in the mediastinum, but only 1% of the tumor is formed by the tumor cells. The rest of the tumor is formed by the other cells, and you can see here the picture. There are the eosinophils, fibroblasts, neutrophils, lymphocytes, there is a fibrotic tissue. So this is not only the cancer cell, but this is the environment which plays a very important role in the, not only in the history, but in the treatment of the cancer as well. I beg pardon. If you have some question, some comments, please do not hesitate, raise your hand or just shout, and we can discuss or cry together. This is another my patient. She was discharged last week. The patient has I can play with this. Okay. The patient has a multiple myeloma. You can see here there are some lesions in the skull. She has a renal failure. She has some pathological fractures, and all was caused by multiple myeloma, which is a B cell, the plasmatic cell originated from the B lymphocyte, but these lesions are formed by the dysregulation of the bone formation, osteoblast and osteoclast, and these cells are settled, the stem cells, stem plasmatic myeloma cells are settled in the niche as well. And the last example is my favorite disease. I'm sorry to say that, but it's very interesting. You know, for decades, so this disease was described almost 15 decades ago. And it was believed that this disease is just the pure accumulation of the lymphocytes in the blood, in the bone marrow, etc. And it was true until the last 10, 12 years, it was discovered that it's a very interesting disease. Because this disease, they have several compartments. It's all B lymphocytes, B-cell lymphocytes, and there is a compartment of the bone marrow, there is a compartment of the blood, and there is a compartment of the lymph node. And these cells can traffic, they can cross over, and they can come from the one compartment to the other one, and they change their behavior, they change their gene expression profile, and it's very important from the point of view of the treatment. And these cells, the tumor cells are able to create what we call the nursery-like cells. They are just so potent that they can behave as a slaver. It means they can create from the other cells the slave. These cells just serve the tumor cell, protect it. Okay, I would like to recapitalize that not only the tumor cells is important, but the tumor microenvironment, which is important to the tumor initiating, for the tumor survival, and it's essential for a tumor cell escapes, and it's important for at least some mechanism of the therapy resistance. Okay, and how we can influence the microenvironment? It's given forever, or can we influence it by some drugs or our behavior? It has been proved, and the whole conference is about that the lifestyle habits can reduce the cancer incidence. Life habits can increase the survival probability. How? By the direct effect to the DNA, by some epigenetic mechanisms, by influence of immunity status. But what about microenvironment? Do we know? Because microenvironment is nowadays very studied field. A couple of years ago, in the National Cancer Institute in Bethesda, very interesting study was performed. They have just draw more than 200 volunteers, the men, and they have the patients who have a bit elevated PSA, which is the substance in the blood which is connected to the breast cancer. If somebody has elevated PSA, there is a significant high probability that this man can suffer from the prostate cancer. And they performed the biopsy, and they examined the gene expression profile of the whole prostate tissue. And then they described or prescribed these patients to change their behavior. They have to behave healthy. It means change the dietary habits, to try to exercise, etc. And what about the results? So you can see that within very short period of time, it's a 3 months period of time, the cardiovascular risk was significantly reduced. BMI, systolic blood pressure, diastolic blood pressure, total cholesterol, LDH, LDL, HDL, the triglycerides was stable. It's not statistically significant. But what is important to say that their psychological functioning was improving as well. So it means it's not only the body, but it's a mind as well. But what is important, that they performed the biopsy within these 3 months again. And what they found, that there is a completely different gene signature. I should explain what this means, gene signature. It means each cell in our body has the whole genome. It means each nucleated cell in our body has all genes we need for life. They are the genes we received at the time when the sperm contacted the oocyte. But the majority of these genes are silenced. It means they are not functioning. And it's a great difference between the different tissues, different cells, because each cell or each tissue have to behave a bit differently. They have a different task. It means that some genes are expressed and the majority of genes are just the silence. Gene expression means that these genes are expressed. And you can see this is the pre-intervention profile, and there are some gene of interest. And the green color means that these genes are not expressed. They sleep. The red color means that these genes are expressed. It means that they are translating, they are transcribing, and the proteins can be formed. And this is the other issue. So it means that these changes of the behavior doesn't mean only that the man, for instance, lost their weight, etc., and feels better, but it really means that there are some molecular biological changes in the microenvironment in the tissue. What about follicular lymphoma? This is the my favorite disease. The patients can live a long time. We do not treat some patients, but some patients have to be treated in very rapid way. And you can see that this is the follicular cells, and there is, again, a number of different cells. They just can serve and behave as a protector to the tumor cells. Around 10 years ago, a very interesting paper was published in the New England Journal of Medicine. And these people, they do not focus on the tumor cell, on the follicular lymphoma cells. They focused on the microenvironment, on the immune cells which are surrounding these tumor cells. And they have been able to describe so-called two immune response signatures. One gene or one gene expression profile is connected with a good outcome. It means these patients with this, and it doesn't matter what the cancer cells are, but just only the circumstanding cells, the microenvironment, its profile, is connected to the better or worse outcome. And you can see that the patients who have the immune response 1, which is inherited, at least from the significant part, have significantly reduced relative risk of death is 1.15 compared to 1. On the other hand, the immune response profile 2 these patients has significantly 10 times higher probability than they die. And it doesn't matter they have the same disease. It's just only because of a different behavior of the immune system of the microenvironment. And at the last ASH, it means the American Society of Hematology meeting in the last December, a very interesting paper was presented. These people, and actually they are the same group which published the paper in the 2004, and they presented the 123 patients which were diagnosed 10 years ago and the median follow-up was 8 years. It means that they followed 8 years all these patients. And they just tried to describe the microenvironment. And they have found very interesting features. The patient, the people who have a higher intake of the fruit, vegetables, starch, who have never smokers, have significantly higher CD7 expression. CD7 is a marker of the T lymphocytes, which are cells very important in the immune regulation. And the patients with the high CD7 expression have significantly better outcome compared to the patients with a low CD7 expression. When we come back, these patients, the CD7 expression is linked to the immune response number 1. And if you remember, I have told that it is mostly inherited. But in this last paper, we can see that probably we can change the microenvironment profile, and maybe we can improve the outcome of the patients by changing lifestyle habits. So, what about the conclusion? Definitely. Genetic events are crucial for the cancer cell onset. It's confirmed, and it's really the crucial event. But the organism response is crucial for the cancer development and progression. It means this is not only the cancer cell, but this is a reaction of the development. And the microenvironment and niche is essential for the tumor behavior and therapy response. And it's very likely that all these can be influenced by lifestyle habits. So I would like to thank you that you are able to survive my talk and to be aware, and I will be happy to answer any question.